Welcome everybody. I'm now going to be giving my second talk on imaging the brainstem tracts. Remember, last week I covered the corticospinal and corticobulbar tracts. Today I'm going to start describing the superior, medial, and inferior cerebellar peduncle. And the superior cerebellar peduncle is also known as the brachium conjunctivum. The middle cerebellar peduncle is also known as the brachium pontus, and inferior cerebellar peduncle is known as the restiform body. And you can see the arrows pointing to the superior, middle, and inferior cerebellar peduncles. Before we continue, we have to talk a bit about nomenclature. Tracts are also known as fasciculi, brachium, funiculus, lemniscus. Peduncle is a connecting structure containing tracts, and lemniscus is a sensory tract, and I'll cover in the future talks the medial lemniscus, the lateral lemniscus, and the trigeminal lemniscus. The superior cerebellar peduncle, or the brachium conjunctivum. The cerebellar cortex is uniquely arranged to allow a vast amount of information to be projected to the central cerebellar nuclei, and from there to the opposite red nucleus and thalamus to the dento-rubral and dentothalamic tracts via the superior cerebellar peduncle. You can see in this diagram the fiber tracts going from the cerebellar cortex to the dentate nucleus, through the dento-rubral tracts and the dentothalamic tracts, which travel inside the superior cerebellar peduncle, to the opposite side red nucleus, thalamus, and eventually to the cerebral cortex. We can see the superior cerebellar peduncle on this coronal T2 images, and this one here, and on the flare image, just lateral to the fourth ventricle. On the sagittal plane, the superior cerebellar peduncle is just slightly off the mid-sagittal plane. And here we can see it on the specimen, and here it's stained in a histologic specimen. We have to separate the superior cerebellar peduncle from the superior medullary velum, which is a very thin layer covering the roof of the fourth ventricle. You can see in this picture from Netter, here's the superior medullary velum right in the midline, and you can see on the T2 image the flow through the CSF to the aqueduct here, the flow of CSF. And if we go a little bit more lateral, we can see the thicker, larger superior cerebellar peduncle, also seen on the specimen in the histology slide. We can also identify the superior cerebellar peduncle on the axial T2 image. You can see it here, very similar to what we see in the specimens, in both these specimens. Now, why bother with all that? The reason we have to know about it is because we now can see the superior cerebellar peduncle on this tractography image in the axial plane. And here it is very similar to the specimen. Let's move on to the middle cerebellar peduncle. Continual postural adjustment involved the corticopalatal system through the corticothalamic and the corticopontocerebellar pathway, which pass via the middle cerebellar peduncle. And here we have the fiber tracts, a huge number of them going to the middle cerebellar peduncle to continue on the opposite side towards the cortex. And again, the middle cerebellar peduncle is easily seen on the sagittal image, or on the coronal image, and on the axial T2 image. And here it is on the specimens. And again, on tractography done specifically for these fibers, you can see the corticopontocerebellar fibers, a large number of fibers crossing from one cerebellum to the other cerebellum via the pons. And you can see all on the specimen, all these tracts passing, breaking up the corticospinal tract, these white little fascicles here. That's because of all the crossing fibers. And you can see again on the specimen here, the corticospinal tract broken up by these crossing ponting fibers. And you can see it again on these specimens and also on this diagram, the separate parts of the corticospinal tract by the, separated by the crossing fiber. And that's why sometimes we'll see the corticospinal tract as little separate fascicle because of these continual crossing fibers. However, on DTI, they're all bunched together. And here we have, again, as I talked last week, the blue corticospinal tract because of the up and down course, or down and up. And these are the crossing ponting fibers, anteriorly and also medially here, behind the corticospinal tract. The middle cerebellar peduncle is seen here in green because of the antero-posterior and the posterior-anterior direction. So the crossing ponting fibers are in red because they go from left to right or right to left. Very similar to what we see over on the specimen and on the tractography, except they're bunched together because of the limitation of DTI resolution. Okay, now the last peduncle we have to cover is the inferior cerebellar peduncle that I'm pointing out here on the coronal plane. Again, the main sensory postural input from the muscles, tendons, and joints in the spinocerebellar tract and as well as the vestibular nuclei enter the cerebellar cortex via the inferior cerebellar peduncles. And again, the diagram here shows the inferior cerebellar peduncle and showing all the tracts passing through it, the two tracts. And again, the inferior cerebellar peduncle is well seen on a sagittal T2, on a coronal T2, and here on the axial T2, where it's easiest to see. That's the region of the inferior cerebellar peduncle, and you can always identify it because the eighth nerve travels from the IAC towards the inferior cerebellar peduncle where the nucleus sits, the auditory and the vestibular nuclei. And notice nicely the inferior cerebellar peduncles here in the specimen, on the axial specimen. Now why again bother with all these? Again, we can see it on DTI. Here's superior, middle, and inferior cerebellar peduncles on specimens, and here they are on a DTI. The middle cerebellar peduncle, the superior, and the inferior, all in green because of their antero-posterior and posterior-anterior direction. Not only on the axial plane, we can see it on the coronal plane. Again, superior cerebellar peduncle, middle, and inferior. And here they are on the specimen. As well on the sagittal plane, we can identify them in red because of their right to left direction, the superior cerebellar peduncle, and barely visible is the inferior cerebellar peduncle right over here. So we can identify the peduncles on the DTIs in all three planes. And again, notice here they are on this image from the literature, but these are images that we did, and I found these, and they're not bad. Although there's a lot of noise, we can see the superior cerebellar peduncle, we can see the inferior cerebellar peduncle, and the middle cerebellar peduncle quite well. Okay, the big question always is, sometimes the neurologist or the clinician will call you and say, our patient has a stroke. Could this be the stroke because it's some restriction on the diffusion image as well as on the ADC map? And here's another patient showing the same bright image in the center on the axis on the coronal plane. Is this a stroke? No, it's not a stroke. It's a normal structure. It's the decussation of the superior cerebellar peduncle. You can see the fibers here crossing over to the other side. So that's the decussation of the superior cerebellar peduncle in this location on the specimen. And here it is on the coronal image, coronal T2 image. And notice, here it is again on the FLAIR image. This is a specimen. It's a large structure. All this white area is the superior cerebellar peduncle. Here's a stained anatomic specimen. All this black is the superior cerebellar peduncle. And this diagram here shows nicely the crossing fiber at the level of the cerebral peduncles, or behind the cerebral peduncle, behind the substantia nigra. And not only that, if we go to the DTI image, notice that's the decussation of the superior cerebellar peduncle, and red again because the fibers go from right to left. So this is a normal structure, not to be mistaken for a stroke. Again, superior cerebellar decussation with some restriction on the DWI and ADC maps, and here it is in the DTI and in the specimen. Now let's look at some lesions involving the peduncles. Here's a stroke involving the superior cerebellar peduncle. An MS case with multiple lesions, including one lesion involving the superior cerebellar peduncle, seen on 3 projections. This is another lesion, not so obvious what is going on here. A little dark, the superior cerebellar peduncle looks a little dark, but if we look at the SWI images, notice the mark blooming, and this, of course, is a cavernoma involving the superior cerebellar peduncle. Another case involving the superior cerebellar peduncle, this bright and dark areas. This was 10 months ago. The patient had a bleed involving the region of the superior cerebellar peduncle, and that's a residual of the cavernoma again involving the superior cerebellar peduncle. Here we have a markedly enlarged superior cerebellar peduncle with abnormal signal, slight enhancement, and this was a glioma involving the superior cerebellar peduncle, as we can see in the coronal plane as well as the sagittal plane. And here it is on the FLAIR image. I'm sorry, the post-contrast image. And this is another lesion involving the decussation of the superior cerebellar peduncle and the superior cerebellar peduncle, and it also was a high choline peak and some enhancement at the level of the decussation. And this was a lymphoma involving the decussation and the superior cerebellar peduncle. Here's abnormal involvement of peduncle, also involvement of thalami, very classic appearance, and this was Wilson's disease involving the thalami, the brainstem, as well as the superior cerebellar peduncles. Here we have a classic appearance involving the superior cerebellar peduncles. This is the molar tooth malformation, also known as Ruble syndrome. It's a complex genetic disorder. There's hypotonia, ataxia, developmental delay. It's a multi-system disorder. Usually the imaging shows dysplastic small vermis, molar tooth sign, elongated midbrain and narrow at the isthmus, elongated and thickened horizontal directed superior cerebellar peduncles, and also absence of the superior cerebellar decussation and the pyramidal decussation. Additionally, there's a high fourth, a vermian cleft, abnormal deep interpeduncular fossa, and some other supratentorial anomalies. Here again is the same patient showing the molar tooth sign and the hypoplastic cerebellum and the very narrow isthmus of the midbrain. Here's another patient showing hypoplastic vermis, the superior cerebellar peduncles, and the narrow isthmus, and all the changes in cerebellum. Sometimes the tonsil may be enlarged. And of course, modern neuroradiology shows that this anomaly again. Here's a case from the literature showing the enlarged AP and PA directed green superior cerebellar peduncles compared to the normal size. And also notice the red dot of the decussation seen normally absent on the abnormal case. And they did some beautiful coronal tractography showing there's no red crossing fibers. Normally you would see the decussation of the superior cerebellar peduncle, the crossing pontine fibers, and the crossing corticospinal tract, but none of those are visible on the abnormal case of Joubert syndrome. And here's a fetal specimen from the literature, a fetal MR in a family that was concerned that the baby may also have this syndrome. And again, showing the horizontally directed superior cerebellar peduncles and two planes. And we see the narrow isthmus here, which is the same size as the interpeduncular cistern, which usually should be much larger. This is another condition, the progressive supranuclear palsy that we followed. These patients present with ophthalmoplegia, dystonia, Parkinsonism, pseudobulbar palsy, imbalance, and cognitive decline. And the pathology involves multiple structures. Again, notice, although it's a little bit off-center, the thickness of the isthmus here compared to 6 years later, where it has this so-called the hummingbird type appearance, where it's much narrower. And also by measurement, I could tell that this was much less in length compared to what it was 6 years earlier. And also there may be some changes, less prominence of the dentate nuclei. Here's an unusual case given to me, of course, by Ajay of a condition called Dento-rubral-olvary atrophy, or DRPLA, involving the superior cerebellar peduncle. It's a complex genetic disorder resembles Huntington's disease, spinocerebellar atrophy, and all kind of other conditions. Again, it was mainly initially seen in Japan, but now some cases have already been reported of this genetic disorder in this country. Illusion has to do with the corpus luisi, which is another name for the subthalamic nucleus. Okay, we finished with the superior cerebellar peduncle abnormalities. Commonly in the middle cerebellar peduncle, we'll have MS lesions, as seen on the two planes here. Here's a 14-year-old with ADEM, again showing a lesion in the middle cerebellar peduncle. Now, one of the interesting things, when I was going over this case with a fellow 2 years ago, the comment was made, why do we see abnormalities in the cortex, on the surface of the pons, when it really should be within the pons? So this is one patient, and the same finding in another patient. The reason for that is the way the fibers travel. Remember here, the fibers are traveling quite anteriorly as well as centrally, and as you can see on this tractography. So what we're seeing is involvement of these pontine fibers, which in this case are at the surface of the pons. So it'll be right over here or right over there on the specimen. So again, this is why we see it here on the two planes, because this is where the pontine fibers are traveling. Same, the other case, same thing. These are the crossing pontine fiber very anteriorly. Here's a stroke on DWI and ADC, and on the T2 images involving the middle cerebellar peduncles. Other lesions we can see, this is a chloroma that involved the middle cerebellar peduncle with some enhancement. This is unusual involvement of both middle cerebellar peduncles, and this was a case of Wallerian degeneration, and you can see it here on the MR, and here it is on this histologic specimen, and you can see why we have that as it relates to the severe bilateral cerebellar cortical atrophy manifested also in the degeneration of the fiber tracts going to the middle cerebellar peduncle. Another unusual condition involving both middle cerebellar peduncles, and that's Fragile X syndrome that usually presents with ataxia, tremor, rigidity, and cognitive dysfunction. There's an unusual case that of MS involving the inferior cerebellar peduncle. We can see in the region here on the specimen. Now, sometimes we have lesions involving where all three peduncles meet. Here on Netter's diagram, we see the superior, the middle, and inferior cerebellar peduncles in this location on the specimen, and here we can see the stroke in the same location. So it would be involving all three peduncles, although here it only shows the involvement of the superior and a little bit of the middle cerebellar peduncle. That would be the location on a normal specimen, MR. Now, all this comes together in this unfortunate patient who's had multiple strokes, and notice now what we can see. Markedly atrophic superior cerebellar peduncle when compared to the other side. Middle cerebellar peduncle is much smaller when compared to the normal side, and the inferior cerebellar peduncle quite small on these axial images compared to the other side. Notice again on the coronal T2, large normal, small middle cerebellar peduncle, smaller middle cerebellar peduncle, smaller superior cerebellar peduncle when compared to the other side, and notice how much smaller the inferior is compared to this side, the normal side. And again, not only do we see it on the T2, but we can also see it on the DTI image. The normal side, the green, middle, superior, and slightly bluish inferior cerebellar peduncle. Nothing here, just a little bit of yellow, no large middle cerebellar peduncle, no superior cerebellar peduncle, and no inferior when compared to the normal. So a lot of changes can be seen on these DTIs. Now, here's a condition which we should be familiar with. A stroke involving a large portion of the left hemisphere, but notice there's also restricted diffusion in the cerebellar hemisphere and changes on the FLAIR image. Plus we see all the changes in the cortex of the opposite cerebral hemisphere. What this condition is cross-cerebellar diaskesis. Cross-cerebellar diaskesis, in Greek it means shock throughout. I don't know why they chose that term, but it results from decrease in blood flow and metabolism in the cerebellar hemisphere contralateral to the supratentorial stroke. And people postulate that it's due to interruption of the corticospinal cerebellar tract. That's most likely the causal mechanism of this remote transneural metabolic depression. You have to also realize that the corticopontocerebellar tract is a massive tract, has 40 times more fibers than all other cerebral cerebellar connections. So again, we're talking about this large corticopontocerebellar tract. Now again, it goes from the various areas of the cortex, the parietal, frontal, temporal, and it travels in the brainstem on either side of the corticospinal tract, gets to the pons, crosses over, and ends up in the dentate and then in the cerebellar cortex. Remember this picture here. And here it is again diagrammatically. Remember when I was talking about the corticospinal tract, I said the cerebral peduncle, the middle, contained the fibers of the corticospinal tract, and laterally we had those other fibers. Those are the corticopontocerebellar tract fibers that are going on either side of the corticospinal tract. So for instance, here where there's a stroke, there's atrophy of everything. So on either side would be those corticopontocerebellar fibers going on either side of the peduncle. And we can see this diaskesis in different studies here from the literature. Here's a stroke on the left side. We see delay in the time to peak, which we usually see on perfusion imaging, and we can also see delay time to peak in the perfusion of the opposite cerebellum. Here we see a stroke and less PET activity on the opposite cerebellar hemisphere. Another massive stroke on nuclear studies. The stroke is on this side, CT image, and notice the small activity on the opposite cerebellar hemisphere. Again, a large stroke on the right side and less activity on the opposite cerebellar hemisphere. Okay, a new condition. What is this? This is the famous hot cross bun, which reflects degeneration of the pontine nuclei and the corticopontocerebellar fibers. And multi-system atrophy, or also known as sporadic olivopontocerebellar atrophy, or MSA, is progressive adult neurodegenerative disorder with unknown etiology and has cerebellar, pyramidal, extrapyramidal, and autonomic disorder. Here we see the classic very small belly of the pons and the atrophic changes in the cerebellum. So again, these are due to the degeneration of the crossing pontine fiber as well as the nuclei within the pons. So again, these are the fibers we're talking about, the corticopontocerebellar tract fibers. This is a case that Amit Mahajan gave me recently, showing this was a 57-year-old multiple system atrophy likely, again showing the hot cross bun that we saw in the prior literature image, again, and it was showing this kind of abnormal architecture. There was an incidental lesion in front of the pons, which some people felt may be a neuroenteric cyst, which was an incidental to the other issues. And the last case I want to show, only because this was followed by T2 imaging for ventricular size on 3 different occasions. Nobody noticed the abnormalities involving the cerebellum. And this abnormality is rhomboencephalosynapsis. These patients usually have ataxia, gait abnormality, involuntary head movement, seizure, and developmental delay. And imaging shows fused cerebellar hemisphere, the folio and denti are all fused, and there's no midline, absent of vermis, and the sulci will cross midline. As we can see here, a fused cerebellum and no vermis. And this is the end of the talk, and we will continue next week with the remainder of some of the brainstem tracts.